Buenas tardes a todos. Es para mí un placer de moderar con Shaira Martínez, la directora médica nacional de Diálisis España, este webinar. Perdóname por mi español, pero voy a hacer lo mejor posible para que me comprendan. En este webinar vamos a hablar de inteligencia artificial en diálisis, hacia dónde vamos, y vamos a presentar también el modelo predictivo de la trombosis en el acceso vascular que hemos desarrollado en Diálisis. Hemos empezado este proyecto hace 2 años y es para nosotros extremadamente relevante la oportunidad de lo presentar a la Sociedad Española de Nefrología. Diálisis es un proveedor de cuidados renales en que su actividad más importante es hemodiálisis, pero también tenemos actividad en diálisis peritoneal, en trasplante de riñón y también en prediálisis. Estamos presentes en 24 países, operamos 452 clínicas de hemodiálisis, un hospital de trasplante en Argentina y tratamos más de 40.000 pacientes en diálisis. Os quiero presentar, en primer lugar, vamos a tener David Jacobson. David Jacobson es el director para el Digital Development en Diálisis y nos va a hablar desde nuestras oficinas en Suecia. Después, Carlos Lucas, Medical Protocols and Standardization Director en Diálisis Global, nos va a presentar el modelo predictivo de la trombosis en el acceso vascular. Al final, vamos a tener tiempo para la discusión, por eso os pido que si tienen cuestiones, lo hacen en la plataforma Zoom. Y sin más demora, voy ahora a pasar a David Jacobson para empezar su presentación. David.
Thank you very much, Fernando. So good afternoon, everyone. My name is David Jacobson, and I am Digital Development Director at Diálisis. So in my part of the presentation, I will go through the basic concepts of artificial intelligence, AI, and a subfield called machine learning. I will try to put this in the context of renal healthcare and share what we in Diálisis see as the challenges and the possibilities with AI in our domain. But first, some background. Diálisis is in the middle of a digital transformation journey where we have incorporated 30 years of dialysis know-how into a digital platform to be able to offer personalized, standardized, and efficient dialysis service at scale. And we have 28 project work streams in 5 digital programs ongoing. First of all, the digitalized clinical workflows, which is mainly about dCare, our new renal information management platform. And then we have AI and novel insights, which includes the type of AI predictive models that we will focus on in this presentation. We have mobile patient apps and services, and our patient app for iPhone and Android is one example. Digitalized operations consisting of several IT systems, including the ERP that support our operation. And finally, connected care, which is about integration and connectivity, both of IoT devices in the clinics, like the dialysis machines, but also about data exchange with external IT systems. And with this, I just wanted to show that our AI projects are part of something bigger and not just isolated AI models. So maybe some of you already have some understanding of what AI is. or at least you are in contact with it if you're using, for example, Apple's Siri, if you are driving a Tesla, if you get recommendations what to watch on Netflix, or if you have a bank that uses AI to detect fraud in your bank transactions. So just a few examples where AI is used in everyday life. But so what is artificial intelligence? Depending on who you ask, you will get different answers, but I like this definition. So machines or computers that can learn, reason, and act in a way that mimics human behavior. Most of the times we are talking about machine learning, which is a subset of AI techniques for learning computer systems to solve tasks based on experience rather than being explicitly programmed exactly what to do. And then we have the orange circle, deep learning, which is basically very large artificial neural networks, or we can call it machine learning on steroids. And one of the reasons behind the AI breakthrough we had in the recent decade. The three main ingredients for the AI success story are, first of all, data. And we are collecting data like never before at an exponential rate. And then secondly, computing power. Machine learning algorithms often utilize the GPU, which is the graphics processing unit in the computer, to perform the calculations. And GPUs have become cheaper and more powerful than in the past. And finally, algorithms. And this is the methods to train a model with the data using the computing power. But it all starts with the data, and often you need large amounts of data with high quality to do machine learning. And in most cases, it also needs to be labeled or annotated data. In machine learning, you need data both for training and validating the model. And data is usually one of the following three categories. And this is, by the way, what MIT is teaching. Sensor data, language data, and transaction data. And data can also be stationary, for example, still images, or a time series, and that would be, for example, video. One of the most powerful machine learning algorithms, especially for large data sets, is artificial neural networks. It's also called deep learning when it's about large networks with multiple hidden layers. These models are inspired by the human brain and how neurons are connected in a network to process information and generate outputs. And each neuron takes inputs and can produce outputs to other connected neurons. And it contains functions and weights. And training a neural network is really about tweaking these neurons to achieve the optimal performance. And this is an iterative process, which is why it's often so computation heavy. So that's a very brief explanation of artificial neural networks as one example of a machine learning algorithms. And I have listed some other popular algorithms to the right. There are three main approaches to machine learning problems. So we have supervised learning, unsupervised learning, and reinforcement learning. And the first one, supervised learning, is by far the most common approach, especially in production use. In supervised learning, the subjects of the training set are labeled. It is typically used for classification problems, and I have an example of this in the next slide, or regression problems, and that is predicting a number. In unsupervised learning, unlabeled data is used, and the goal is usually clustering to find natural groups in the data. Reinforcement learning is suitable when training a model to make a sequence of decisions. It is often suitable for game-like problems and uses rewards and punishments in the training. So here is an example of supervised learning for classification. Imagine that we want to develop a model that can classify images of cats and dogs. And we have a large training set where images is labeled as cats or dog. In the training phase, we feed the images together with the labels to the model, and we're tweaking it for optimal separation of the two classes. And we now have a model that can assign the label cat or dog to new unknown images previously unseen by the model. We then validate the model with a separate test set to measure the accuracy. And the validation result will include numbers like true positives, false positives, true negatives, and false negatives, or sensitivity and specificity. And depending on the problem you want to solve, you can adjust the model to favor sensitivity at the cost of specificity or the other way around. As a last comment for this slide, imagine that instead of cats and dogs, we want to predict vascular access thrombosis or no thrombosis based on dialysis data. And this is basically our new VA thrombosis prediction model, and we will get back to this model later in the presentation. So what happens if we send images of blueberry muffins into our model that is trained to classify cats and dogs? Or if we send an image of another animal? The answer is that our model is very narrow, and classifying images of cats and dogs is the only thing it knows. We need to make sure that we don't feed anything else to this model when using it in production. And with today's AI technologies, this model may outperform a human in this very, very specific task, but it cannot go beyond that. And what happens if we have bad quality of data and we have blueberry muffins hidden in our training data, labeled as dogs by mistake? This picture, which by the way is a viral meme in the machine learning community, also illustrates that the model will never be better than the data it's trained on. So we need large amounts of high quality data to do machine learning, and it needs to be diverse enough to cover all possible scenarios that the model will encounter in production. In this example, that means different types of dogs of different sizes, colors, and so on. And we need to clean the data from any blueberry muffins that might be hidden. So this was my take to explain the basic concepts of AI and machine learning. And now, how is AI used in healthcare? The possibilities are many, of course. AI can increase both the efficiency and the quality of care. It can increase workflow efficiency by assisting or automating triage, scheduling, prioritization, and protocoling. It provides diagnostic support and detection, and it can assist in patient and medication management. But there are also many challenges, starting with the availability of data. Tech companies usually don't have any clinical data by its own, but need to collaborate with hospitals to get it. And clinical data is often stored in systems from third parties, and hospitals are dependent on the system vendor of these third-party systems to extract the training data and integrate an AI model in the system in the end. So collaboration is therefore needed between tech companies and caregivers, between data scientists, software engineers, and medical domain experts. In the case of unsupervised learning, the data has to be annotated or labeled, and sometimes this is manual work and something that medical experts needs to do. For example, assigning the gold standard diagnosis to the medical images. And this may be time-consuming and expensive. Then we have data privacy issues like GDPR. An AI model is also not usable on its own, but needs to be integrated into the clinical IT systems and applications to make it available to the end users. Transparency and acceptance, also very important for AI in healthcare. And AI is often referred to as a black box, but there are methods to explain the output and why a model came to a certain decision. For our VA thrombosis prediction model, we use so-called CHAP values for the explainability. And then we have regulations. AI models in healthcare are often considered a medical device if put on the market, with all the documentation and certifications that comes with that. And finally, transferability. It's not always straightforward to transfer a model from one institution to another or to a different population. Sometimes the model has to be retrained with new data to use it in a new context. When it comes to renal healthcare and dialysis, we in Diaverum see many possibilities for AI and machine learning also here. So looking again at the three categories of data used in machine learning, we collect data in all three buckets in our dialysis clinics. Connected dialysis machines provide measurements during the dialysis session, and there are also other measuring devices in the clinic. Between treatments, patients can be equipped with wearable monitoring devices, and this is examples of sensor data. We have language data in the form of patient notes and reports, and there is a special field in machine learning called natural language processing, NLP, that has made great progress in recent years. Transaction data is all the patient info, medical information, treatment data, lab data, and prescriptions, typically stored as a record in a database. Some of the possibilities for AI applications in dialysis that we see includes predict complications for CKD patients, and our VA thrombosis prediction model is one example of this. Predict the risk for hospitalization, rehospitalization, and mortality. Prescription management, for example, assisting the physician in prescribing anemia and bone disease medication. And we have new clinical insights from our data through unsupervised learning, finding new insights. On a high level, the development of a model consists of these three major steps: data collection, model selection and training, and finally, model validation. And our VA thrombosis prediction model was trained with around 340,000 hemodialysis sessions from around 3,600 patients treated in Portuguese clinics in 2020. And the input data was collected from Gdpr, our renal information management system. And it includes demographics, treatment data, and lab data. And the incident reports were used as the labels, the ground truth. The use case for our model is to predict thrombosis in fistulas and grafts 7 days before the episode occurs. And 15 different machine learning methods were trained and evaluated for this use case. And for this use case, logistic regression showed the best performance. The model was validated with 2 large data sets from Spain and Saudi Arabia, previously unseen by the model, and this resulted in a very similar performance to the Portuguese data set. And then the next step was to integrate the model into our clinical applications and the workflows, and this is something that Carlos will tell you more about in the next part of this presentation. In parallel with our AI projects, we are building our own AI development factory because AI projects are in many ways different than traditional software development projects. So our AI factory includes a development process, a cross-functional team organization with roles and responsibilities, and a technology stack with machine learning toolkits, data pipelines, and computing power. We have deployed our VA thrombosis prediction model in Portugal, Spain, and Saudi Arabia as the 3 first countries. And the plan is to do the rollout across the Diaverum group in the next 18 months. But the AI project doesn't end here. We see the AI project model as a cyclic process. And we will continuously monitor the predictions and the model accuracy as new data is collected in our clinics. The plan is also to retrain the model at regular intervals with new input data and with country-specific data if needed. So this was all from my side. Thank you very much for listening. And I will now hand over to Carlos, who will present our VA prediction model from a medical point of view. Thank you very much.
Thank you very much, David. Okay, so good afternoon, everybody. So my name is Carlos Lucas, and I'm the Medical Protocols and Standardization Director for Gdpr Global. And I'm delighted to be here in this webinar speaking to you about this vascular access thrombosis prediction model. To start, let's talk a little bit about because it provides context to the development of the whole model, a little bit about the clinical strategy in Gdpr Global for the next year. So if you start at the top of this slide, you can see standardized clinical programs. So this is actually a major cornerstone of our practice to have standardization of care. And why? First, of course, because standardization of care is something that has proven again and again that it improves results, it improves efficiency, but also there's another thing. Every time that you have a standardized clinical program, you will get standardized data and curated data. And we can then use that data to develop many applications, including, of course, AI models for several problems. And if you look here at the main areas in which we focus our standardization of care, you can see vascular access management. Vascular access care is extremely important in our clinical strategy, and this has a central role in the deployment of that strategy. We also focus on hospitalization reduction, of course, focusing on things that really matter to patient, on respiratory infection reduction, and this became very important, of course, during the COVID pandemic. We also focus, of course, on diabetes management, cardiovascular disease intervention, and therapeutic algorithms. So several key areas of our clinical care are being standardized, and with this we improve results, we improve efficiency, and we will obtain data that we can use to create, for instance, AI models. The other thing, of course, is that even though our company focuses more on dialysis patients and on providing dialysis, we also have in the company, we provide transplant services. We also take care of patients on the CKD 3 and 4 stages. And so this is becoming also a chronic condition management. And here, again, we also focus on trying to standardize care. The next thing that you see here, it's the patient care evaluation. So this is absolutely critical. How do we measure clinical performance? This is critical to knowing exactly what you're doing and to try to improve those the care that we give. And so if you look here, we have clinical performance measurements. So we developed a new system of 31 parameters in 8 key areas of care in hemodialysis that we track in all clinics, and we can actually know what is the score for each one of the individual patients and how can we improve it. But not only this, we also focus, of course, on patient self-reported outcomes. This is becoming increasingly important all across healthcare and especially on dialysis. And so we focus, of course, on trying to see trying to measure the quality of life of our patients and also the perception of the care that they are receiving. And this is also central to our clinical strategy. Finalizing, we have this AI-enabled personalized care. So the idea is, of course, to provide care as personalized as possible, and using AI tools will be something that will help us in terms of predictive analytics, risk stratification, mortality, hospitalization, vascular access problems, and also to devise individualized therapeutical medical protocols. So this is the background that we have in terms of clinical strategy, and it's in this background, in this context, that the development of the vascular access prediction model and other models using artificial intelligence will be done. So the first thing is, of course, when you try to develop a project using artificial intelligence or other technology, you must look at what are the major, of course, technological trends in healthcare. And if you look here on the left side of the slide, you can easily see that there are many technological trends in healthcare, and many of them with the possibility to completely change the way we deliver care and the way we do things in healthcare. And you can see we have things that like artificial intelligence, but also Internet of Medical Things, blockchain. Each one of these technologies will have the potentiality to really change the way we practice medicine nowadays. So, and this is of course, my presentation is more of a clinical view of these things, and this becomes extremely important for clinical people, for doctors and nurses, to be at least to have a basic knowledge of each one of these technologies. And this is important not only because this is going to happen and you need to adapt to it, but also, of course, you need to be critical about this. And if you have your institution, your clinic, or your hospital that is proposing you to use, that is asking you that you must use some kind of AI model or some kind of other technology, you should be critical enough. You should understand what is going on. So it's absolutely critical that doctors and nurses become literate in this kind of digital technologies. But when you are developing a new system, or you're developing a new project in artificial intelligence, for instance, you should not start with the technology. You should start exactly where it really matters, and where it really matters is the patient. So you should go from patient problems, what do we need to solve, what do we need to improve, and then go into the technology, trying to look for solutions. And that's exactly what we did here on the AI vascular access prediction model. So what really matters to our patients? Okay, so this is an extremely important question. There are many things that really matter, but we have there's a very interesting initiative. It's this ICOM, which is the International Consortium for Medical Outcomes, and that they define actually for each one of the chronic conditions a set of outcomes that are considered especially important. And if you look at the chronic kidney disease, outcomes that really matter, you can see. Then, first of all, you have here on the right side, you have patient-reported health and well-being. So things like fatigue, pain, physical function, and health-related quality of life are absolutely critical and are outcomes that matter for all chronic kidney disease patients. Then you have survival. Of course, survival is key. It's an outcome that matters a lot to all patients. Then you have outcomes related to the burden of care, like hospitalization and cardiovascular events. Then if you look at this side on the left, okay, so these are outcomes that matter to patients according to modality of, so if you're talking about hemodialysis, the outcome that is most important is actually vascular access survival. If you're talking about PD, the outcome that is important is survival of the technique of peritoneal dialysis. If you're talking about transplanted patients, of course, it's kidney allograft survival and malignancy, not having malignancy, of course. If you're talking about patients that are not still on dialysis or PD or transplanted, of course, maintaining their renal function is the outcome that really matters. But the key word here, and in context to this specific talk, we have that in terms of hemodialysis, the outcome that really matters to patients that was identified by this international consortium as the most important, it's actually vascular access survival. Okay, and so I know that many of you have think about this. So when we have a vascular access thrombosis in a patient, this actually has an impact on several levels. Of course, this patient will need to do an invasive procedure to try to recover the vascular access. Of course, it might not be possible to restore patency in some cases, even if you have the best surgeons with the best results, the success rate, it's not 100%. So this will mean that you will lose a percentage of accesses that will thrombose, and this will cause a lower overall vascular access survival. Then, of course, we have a great discomfort and disruption in the life of our patients. This is something the patient goes to the dialysis center, the vascular access does not work, he needs to go to the hospital or in any other place, he needs to have an intervention, so then he needs to do dialysis at another time, and so this is, of course, very disruptive for the life of our patient. Of course, you have a real risk here. The patient that has a thrombosed vascular access is theoretically at risk of hyperkalemia or fluid overload. Okay, and this can cause problems, of course. You have a higher risk of hospital admission, and this will lead to higher costs, not only due to the hospital admission, but also, of course, due to the invasive procedures that are needed to recover the vascular access. And you also have a higher risk of mortality. And I want to draw your attention to this part, that we already knew that vascular access thrombosis was something that would reduce the survival of the vascular access. But now, with this article that you see that was published last year, we actually have very strong evidence that the vascular access thrombosis also increases mortality for our patients. And these are the main conclusions of that work, of this article. An AVF thrombosis should be considered a major clinical event, is strongly associated with increased all-cause and cardiovascular mortality in hemodialysis patients. And so we now know that vascular access thrombosis not only reduces the survival of the vascular access, but it will impact on the survival of the patient and increases all-cause and cardiovascular mortality. And so if you look at these outcomes that really matter, and if we are thinking about thrombosis of the vascular access, we can see that thrombosis of the vascular access not only impacts on survival of the vascular access, but also on survival of the patient. It increases hospitalization and, of course, causes pain and other kinds of disruption in our patient's life. And so preventing vascular access thrombosis is something that is critical and extremely important. So what are the strategies that we now have to try to prevent vascular access thrombosis? So we do have strategies like physical examination before each hemodialysis treatment. We can have strategies like access flow measurement, like a close following of relevant treatment parameters like bleeding time, like venous pressures. We can use ultrasound, and we can use it in a protocolized manner, in a standardized manner. All of these measures actually reduce or they have the potential to reduce thrombosis rates, and they have lots of merits, but as you know, they also have lots of limitations. And so, of course, the main goal of each monitoring and surveillance program is to detect early signs of dysfunction of the vascular access, then act upon them to reduce thrombosis and permanent loss. So the question becomes, how can we improve our ability to identify these accesses at risk? And this is exactly what we set out to do in the Averum when we looked at this major problem of our patients, that is vascular access thrombosis, and we set out to test the following idea. Can we use artificial intelligence, machine learning technology, using data routinely collected from our patients in treatments to predict vascular access thrombosis? And a few words about this. First of all, the team that developed this is, of course, a multidisciplinary team, and also a multi-geographical one. So this is a team that has people from five different countries, and also with very different backgrounds. So in this team, we have data scientists, we have data engineers, we have software developers, we have software engineers, designers, we have project managers, and of course we have nephrologists and nurses, dialysis nurses. So this is a very multidisciplinary team that went out to test this. And the other thing I want to draw your attention is that we were able to do this because we had this data, this standardized, curated data that we already have from many years and from many treatments, so that was reliable data and that we can use to create this vascular access thrombosis prediction model. And so after development, and David already talked about the development of this AI model, what are the main features of this model? So this model provides a prediction 7 days before the event. And when we look at the performance of the model, we can see that it has a detection rate of 75% of cases. So in 4 thrombosis cases not identified by the current monitoring and surveillance strategy, the model identifies correctly 3. Okay, let me draw your attention to this. So these results, about 75%, are pretty similar in Portugal, Spain, and Saudi Arabia. And let me tell you that the quality of care that is done on those 3 countries in the Averum in terms of monitoring vascular access, it's extremely good. Okay, so we have low thrombosis rates in these 3 countries, and so this is 75% of the cases that were not detected previously, even with best practices. Now, the other thing is, of course, this model is not 100% precise, and we do have a 25% false alarms, and we are now working actually to try to reduce this number of false alarms. Now, a prediction is calculated at the end of each dialysis treatment. The model uses several variables that include demographic data from the patients, treatment data, findings from the monitoring and surveillance, and lab results from the patient. And also, we made a significant effort to try to explain the model. So this is a very important topic, and is something that David also touched upon. It's very important in healthcare, every time you have an AI model giving predictions, to be able to provide the clinicians, the doctors and the nurses with an explainability of the model. And I will speak a little bit about this in the next slide. So, and what is the main purpose of this model? So the main purpose of this model is that the results of the predictions will be used by the clinical teams, and they should integrate this with their current monitoring and surveillance findings to inform better decisions and try to prevent thrombosis episodes. So this is the main goal of the vascular access prediction model that we have. This is some pictures that we have from the model. So you can see here the ROC curve for the model, and you can see the features that were identified. If you remember, David talked about this. So we started with 156 features in the data, and then due to a methodology, an AI-specific methodology of feature selection, we actually ended up with about a dozen features that are important and that allow the model to make the predictions. And so how does this work in practice in our clinics? So a nurse adds the treatment to our system. All the data goes directly to the AI thrombosis model that then comes back with a prediction. And so it says that vascular access is predicted to thrombose in the next week or not predicted to thrombose in the next week. Another thing that is extremely important, so we now have a very significant problem, which is vascular access thrombosis. We have the data, very big and very accurate data regarding this. We have now a model with this performance that I talked to you about, but we need to optimize the human-computer interaction in the clinics. So the people on the front line, the doctors and the nurses, should be able to easily access the predictions, and this is what we have. What you see here is exactly what our doctors and nurses are seeing in their systems when they connect the patients. This is another example. This is exactly a snapshot from that, and what you get is the type of vascular access of the patient and if the thrombosis is predicted and the date the prediction was done. Okay, and of course this is extremely useful, and this is integrated seamlessly into the workflow of the nurses and the doctors, and there's really is no way that you cannot see that the model is giving a prediction of thrombosis for a specific patient. Then this is explainability, and this is extremely another situation that is extremely important. Okay, and this is part of the best practice guidelines when developing AI models for healthcare. So the users, the end users, the doctors and the nurses should be able to see what is driving the prediction. Okay, and in this model we address this using these SHAP values. So basically, what is a SHAP value? A SHAP value gives us an idea of the importance of a specific factor in the prediction. So if you see here, for instance, arterial pressure, this has a significant effect on the prediction, and it's pointing towards thrombosis, which is this side. Venous pressure for that specific patient, the value of venous pressure that the patient has is actually pointing in the other direction. Okay, and with this, you can have an idea of what are the parameters that the model is using to give a prediction of thrombosis or of no thrombosis. This makes the model more explainable, but does more than that. Actually, it also allows for the medical doctors and nurses to try to do a kind of quality check on the model. Is that value correct? Imagine that you have an incorrect value here for KT over V because someone introduced it incorrectly, and you see on the sharp values that this is the main factor that is driving the prediction. So this is the way this should be used. Explainability of AI models is absolutely critical. So in conclusion, we do have an AI model that addresses a real problem in renal care, which is vascular access thrombosis. We do have a detection rate of 75% of cases previously missed, even with best practices in these countries. This is a human-centered tool. So this is a tool that is developed to support the clinical teams, not intended to replace clinical judgment. Okay, so this is another piece of information that the clinicians and nurses have in order to decide to do some kind of intervention on the access or not. But of course, they should take the prediction of the model into account, but they should also take their common clinical judgment, the physical examination, etc., to come up with a final conclusion. Also, this is a model built on complete transparency of the composition, provenance, and quality of the data. And we, of course, also struggle to do an optimized human-computer interaction. We integrated the model in all our clinical management systems, and we try to make it as explainable as possible. And so thank you very much for this, and I think we are now open to questions.
Thank you very much, David and Carlos, for your very good presentations. And I think for sure we will have some questions, and you can still put some additional questions if you want. I will ask now Shaira Martinez, as I told you in the beginning, she's the country medical director for Diaverma Spain. So Shaira, please, I would like you to moderate now the queries for this session.
Thank you, Fernando. Thank you, Carlos and David, for this excellent presentation. David, I have a question for you. Are there any plan for any revision to be made to this model in the future as more data collected in order for further increase the accuracy of the data?
Absolutely, this is very much the intention. And actually, for each new country where we introduce the model, we plan to first validate with country data. And if needed, we will collect data from that country, from clinics for that country if needed, and retrain the model. And once in production, the model will also be monitored, so we can actually follow up on the prediction accuracy to make sure it doesn't drift from the original accuracy. And plan is also to retrain the model when we have more data, up-to-date data in the future.
Okay, excellent. Dr. Carlos Lucas, another question. Are you worried about that this may lead to unnecessary exploration or examinations to our patients with this new model?
That's a very good question, Shaira, and that's a very important one. And that's exactly why we say that this is a human-centered tool. Okay, so the idea, and this is what we are requesting the medical doctors, is that this model should be something that will help the diagnosis of the patient, but the final decision is always of the doctor and the nurses, and they should integrate the prediction of the model with the rest of the clinical data and the clinical elements that they have. So we do not recommend that you do some kind of exploratory, especially invasive analysis, taking into account only the results of the model. Okay, that is not the way this should work. This should be another thing. So this should be basically, if the model says that there's a high risk of thrombosis, you should assume that this patient has in fact an higher risk, and you should keep a close eye on that patient, maybe do a more thorough physical examination, eventually do an ultrasound if you find something on the physical examination, and only then should we refer the patient to some kind of invasive procedure. So this should be the usual workflow. So this is remember, I mean, this model is not 100% correct, and actually no artificial intelligence model is 100% correct. So in a way, you can say that all artificial models are wrong, but some are useful and some are not. And the expectation here is that this model can be very useful as a screening test in identifying patients at risk and identifying especially those patients that you need to take a closer look.
Dr. Carlos Lucas, do you think that it's or will be possible to reduce the false positive cases?
Yes, absolutely, absolutely. So as we showed, we have about 25% false positives now, which can be a little bit demanding on the clinical teams. And so what we are working now is trying to make the model more precise, so less false positives, trying to reduce the false positive rate, but without sacrificing the detection rate, okay? Because there's a delicate balance. Of course, if we make the model very precise, so you don't have false positives, you can run the risk of having also a lower detection rate. And now we are working closely to reduce that. And let me tell you that, for instance, in Portugal, right now in Portuguese clinics, we have an 8% false positive rate. So the results are very, very encouraging. Yeah.
Okay. David, another question. What has been the main challenge in this developed model?
We had many challenges in this project. First of all, it was the first proper real AI project that we did at Iverum. We have previously done some development of simple AI model, let's say, decision trees and rule-based models that supports, for example, anemia management. But this was the first one involving machine learning and large amounts of data. So I think I mentioned in my presentation also that an AI project it's quite different from a, let's say, a traditional software development project, which is quite predictable. You have your requirements and you develop something. But in an AI project, it's very research heavy. Some compare it with drug development. And you can very late in the process, when you put it in production, you can realize that you have some defects that was very difficult to foresee. I think for this specific use case also with thrombosis prediction, as Carlos mentioned, we have a very low rate of thrombosis incidence in these countries. And I think in general, that's also the case. It's something like 0.1 to 0.5 per patient a year. So when we collected the data set and the two classes, thrombosis and no thrombosis, it was a highly unbalanced data set where we had most no thrombosis actually. So we had to compensate for this, of course, which reduced the data. But luckily at Iverum we have a lot of data from our clinics collected over a long period of time. So those are, I would say, two main challenges that we had. We first proper AI project where we had to develop our AI factory also, and then this highly unbalanced data set that we had to deal with. And other challenges as well, I can keep on going, but I will stop there for now.
Yeah. Okay. For any one of you, why the Iverum select Portugal and Arabia Saudi and Spain for the starting of this model?
Well, I can start, David. Then you can. So the quality of care in the Iverum in those three countries, Portugal, Spain, and Saudi, it's extremely high. Okay, and so we wanted to see this, and we wanted to start developing the model in these countries with this very high quality. On the other hand, we also have very good quality of the data. Okay, so if you remember this, it's extremely important in these cases of supervised learning of the model to be able to adequately label the data. So we need to know exactly if the patient had a thrombosis, no thrombosis, etc. And the data from these three countries is also excellent. Okay, so these were based, and also this is the countries that we are testing now the model. Okay, in these three countries in production, it's also that, and we are hoping for meaningful feedback from that. So those are the main three reasons why we chose these three countries, mainly due to the high quality of care, high quality of data, and also countries very suitable to test now this kind of model. But of course, this model, I think it will have even it can be even more useful in countries where the quality of the care is not that great, okay, or has some deficiencies, because you can have some deficiency in terms of training of personnel and etc. And so this model can be even more helpful in countries where you do not have a high quality of care like you have in these three. But let's see.
Okay, I have another one. What are the usual actions of medical staff when the prediction risk of thrombosis is positive? From Dr. Ramon Sarancho.
Yes, so that's exactly, that's a very important thing. So this should be seen as a screening method, okay, that identifies vascular accesses at risk. And so what does this tell is that clinicians should take a closer look at that patient. And this may mean several things. The first thing, you should do a proper physical examination of the patient to see if there's something wrong. If you have access to ultrasound, then you do an ultrasound. And then, only then, should you decide if you send the patient to some kind of invasive procedure, okay? So this should flag patients at risk, and should be patients that you should keep a close eye on it, should do a full physical examination, and probably during that week that is predicted to thrombose, to keep a closer eye on that patient. But do not do some kind of invasive procedures or more sophisticated investigations only because the model tells you so, okay?
Okay. When collecting the data, do you ask nurses or physicians to make their own naive estimation of probability of thrombosis of the vascular axis? Is there a way to compare the good feeling with the result of the model?
Okay, I understand. So so before the prediction, you mean? Yes, before the prediction?
Yes, or to compare what the nurses, yeah.
Yeah, so basically that question is the human agreeing with the model or not?
Yes.
So that's it, okay. That is something that we have planned to study now in the future, okay? So once we pass this initial stage where we are rolling out the model to some clinics in some countries, we have now 30 clinics that are using it, we will start studying this formally. So we will see if the prediction is agreeing with the doctors and the nurses, and that's a very important subject. And we will also see if using the model in a proper randomized study will reduce thrombosis rates or not, okay?
And if you allow me, I just would like to add that these predictions were made in an environment where the nurses and the nephrologists did not predict this thrombosis. They were not detected by the clinical teams. I think this is very important. So these 75% were missed by the best clinical practice that we have in our clinics.
Okay, I agree, Fernando. And another question. What does the renal care industry need to learn from this breakthrough for our patients? Dr. Carlos?
Yeah, well, okay, so I may give part of the, I think this is what the renal care industry, and I think all healthcare industry actually, the whole of healthcare needs to learn that these tools are coming, okay? We need to have doctors and nurses that are knowledgeable and literate about this kind of technologies, and critical also, and preferably, and this is a clinician's view again, I think you should include doctors and nurses in the development of these tools. I think that's to have the domain experts, as David told us, in an AI factory, it's extremely important. And so I think that all of these tools will be very useful. They are coming. If you can develop, or you should develop, these kinds of tools using domain experts, namely using doctors and nurses also in the core team. Yeah, I think those are key takeaways, I think, from this.
Okay.
Yes.
Does Gdpr have plans to public or to realize the results of the use of this model?
Absolutely, Shaira, absolutely. So as I was speaking, so we did publish in a congress the results of the development of the model, but we plan to do a proper randomized study on the hard outcome of this, thrombosis, no thrombosis. So what we really want to know is if using the model in our clinics is reducing the thrombosis rates or not. And for that, we are planning to do, once we finish the rollout, a proper randomized study on that, and we will publish it for sure. Yeah.
Okay, we have another question. Does the dialysis centers where they have implemented this model have the primary vascular access surveillance protocol standardized?
Yes. Yeah. All of them. So the ones that they have implemented now, so in those 3 countries, they work exactly on the same way. So they have the same standardized monitoring and surveillance. At least the basic, the core monitoring and surveillance of our patients is done exactly the same way. Yeah. And that's one of the advantages of having standardized care, is that we actually have digital workflows that people need to follow when they are monitoring the vascular access. And so we can be pretty sure that the core monitoring and surveillance of the patient is done more or less the same way in these 3 countries, okay? But we need, of course, to bear in mind, and David also talked about this in the presentation, that the populations from country to country may differ a little bit. And this may require us to do some changes to the model once we jump from one country to the other.
Okay. I think that we must close this session. We are very happy and very proud of sharing this presentation model of artificial intelligence to you. And thank you for Carlos Lucas and David Jacobson for this excellent presentation. Y bueno, voy a hablar un poco en español. Muchas gracias a todos por su asistencia. Estamos muy contentos de poder compartir esta herramienta de inteligencia artificial que desde luego viene a complementar el trabajo realizado ya por todos los profesionales sanitarios en los centros, en las unidades de muy importante en la calidad de vida de nuestros pacientes.
Muchas gracias, Sara. Muchas gracias a todos y también a la Sociedad Española de Nefrología. Buenas tardes.
Muchas gracias a todos. Hasta luego.